Good afternoon. If you're on European time, that is, you're very, very welcome on behalf of MedTech Europe to this webinar, the second of two webinars we're having on the topic of the future of diabetes care in Europe. I'm chairing this session. My name is John Nolan. I'm a diabetes specialist based in Dublin, in Ireland. Earlier this year, in the springtime, MedTech Europe decided to conduct in-depth interviews with experts from all over Europe and beyond on the topic of the vision for the future of diabetes care. What happened after that is history and historic, because this coincided with the onset of the COVID pandemic, which has changed our lives completely. So the in-depth interviews were conducted by myself and Tanya Valentin from MedTech Europe during April and May, mostly of this year, with 20 people from all around the world, clinicians, researchers, people with diabetes, and people in the industry. And we produced a vision paper on how these people see the future of diabetes care. And in our first webinar, I spoke to some of the contributors of that vision paper to debrief them on what they saw. Interestingly, the emerging view from the paper and from the experts we have engaged with is overall very positive, despite the fact that we're in the middle of the worst viral pandemic in 100 years, and despite the fact that COVID is particularly dangerous for people with diabetes and associated complications. Despite all that, the vision paper highlights a number of very positive things. Experts that we have engaged with are highly confident that there will be a big transformation in diabetes treatment and care in the years ahead. They're also highly positive that digital care will become the norm and that digital tools will really improve patient care and improve the quality of life for people with diabetes. And I think what we found both in the vision paper interviews and in the first webinar we had, that people feel that the COVID pandemic has actually accelerated the uptake of these virtual tools and shown their usefulness and forced change and actually allowed a lot of things to happen that would otherwise maybe have taken years. So the expert felt that there would be much greater use of technologies and artificial intelligence. And some have even described that, the routine clinic appointment for people with diabetes will be history, that it won't happen, that many people with diabetes will avail of telehealth and occasionally have an in-person visit. The vision paper, which, by the way, you can if you haven't seen it, you can download it from the MedTech Europe website. It also describes a vision for accountable and value-based care, which will really and truly be built around the journey of the person with diabetes. Very positive and very visionary, I would say. Now, it's not all rosy. We asked a number of set questions to every expert we spoke to. We asked them about the type 2 pandemic. Will the type 2 pandemic be reduced by 2030? Unanimously, the experts we spoke to said, no, it'll continue. And a number of challenges are highlighted in the paper as well. There's the danger that hopefully after the COVID pandemic has waned, that we'll go back to the way it was before, that we'll revert. Experts have spoken about inequality in patient access, especially gaps in digital literacy among people with diabetes. Problems with the systems that we have and questions around the privacy of data. So those were all the findings in the vision paper, and I'd encourage you to read it. It's a short document, 13 or 14 pages, and I think well worth the effort. So today we're having our second webinar on this topic, and today it's not about the vision paper, it's about this vision in action. So we have a panel of 4 experts here, a mixture of clinicians, people with diabetes, someone from the industry, to talk about what's happening on the ground. Is this vision, to what extent is this vision already in action, and how do today's panelists see this being implemented in the future? So that's the theme for today. And after I have spoken, I'll interview these panelists one by one. And after that, there'll be time, good time for question and answer from yourselves out there. And we're very interested to see your views on this. Some quick practical housekeeping. We'll have the question and answer session at the end. Your questions will come in to me, and I will do my best to put as many of them as we have time for to the panelists. Use the chat function in Zoom here to submit your questions. And just to remind you, this session is being recorded today, and later when the webinar is finished, it will be made available on the MedTech Europe website. So that's the plan for today. It's about the vision for future diabetes care in Europe, and that vision in action and how our panelists see that. So let me go straight ahead to our first panelist for today, and I'm delighted to introduce Bastian Hauck. Bastian is very well known in the field of diabetes in Europe. He's a leading advocate for people with diabetes. He's from Berlin, but I think he's a true European, and anytime I talk to him, he's somewhere else. At the moment, he is on his boat in Copenhagen, and he might say something about that. Bastian has been a great communicator about his own story of type 1 diabetes for many years. He has been a huge innovator in the field, founding an organization called ddoc.de, which you might say something about. And he is on multiple board roles in terms of diabetes policy and action, and he is a board member for IDF Europe. Bastian, it's a real pleasure to have you on this webinar today. And it's very important that we hear from you first about your vision, your view of this vision of the future of diabetes care. So can I start by asking you, Bastian, you're an advocate for people with diabetes in all the roles that you have. Where do you see this going for people with diabetes today? Where are the opportunities for positive developments? How do you see it?
Yeah, first of all, John, thank you very much for having me here, today. But also I'd like to go back to the paper you just mentioned. Thank you very much for including not only me, but other people living with diabetes in actually drafting that and having these interviews with us and asking us for feedback, because that's still sometimes not the case. You know, sometimes these papers, these policies are being drawn up, and then at the very, very end, maybe somebody actually living with diabetes is asked, oh, by the way, do you agree, yes or no? And it's a sign off. But you actually came to us not only to me, to many people living with diabetes very, very early on, and really asked us for expert input, as you did with many people from the industry, from researchers, from doctors, from the policy scene. So it was on an eye-to-eye level. Thank you very, very much for doing this. You and of course everybody else involved on the MedTech Europe side that were involved in drafting this. Now, some of the answers to that very big question, where do you see this going, are actually reflected in that paper. And I saw some passages that I remember having contributed similar answers to. So my best advice would be for people to actually do read it, do go through some of the policy recommendations. But very generally speaking, what I found interesting, especially over the last 6 months, is that for not the first time, but for the first time for many, I'd say, we realized that some of the things we've been thinking about, talking about when it came to digital and digital health, etc., for the first time for many people out there, many people living with diabetes, it became a reality. It was not just something one would talk about. It was not something related to just apps, and some people are more comfortable using them and others are not. I personally don't use apps so much personally. But it became something that works for many people in that, you know, we had severe lockdowns all over Europe. People were not comfortable maybe going to see the doctors, or they weren't allowed to even see the doctors, or they just didn't have the access that they usually had. And suddenly it's some of the very basic things that started to kick in, like video consultations, like phone calls, like emails. It's sometimes the very basic things that matter most. And these are digital today. But I found that to be the most interesting thing, that it changed the awareness and also the acceptance on both sides. I'm talking for people living with the disease, but also for many HCPs and nurses out there who were in the past maybe not always open to doing this. With COVID kicking in, I think that has dramatically changed over the last half year.
Okay, Bastian. So, I mean, I think that's what we heard from you and from many others, and I think it is reflected in the paper. We didn't plan, by the way, to build a vision around COVID. This happened by accident, and for a while we thought we'd have to wait. But as you say, Bastian, it kind of triggered a lot of things that just had to happen. Uh, One of the things that is in the paper, Bastian, I'm curious in your thoughts on this, is that, yeah, we're going digital. That's the way it is. And as I mentioned in the introduction, that's the end of the routine clinic appointment. I personally think that's a bit extreme. I'm interested in your view of that. Is that the way it is, or is that a little bit sort of over the top?
Well, we had a discussion about this earlier, so I don't think it's the end of routine care, but I think what we are seeing is that routine care will change. And we've always been advocating for this. We've been advocating for more integrated care, for more, not go for the one size fits all, come in every 3 months, for example, but let's be more common sensual with this. Let's see where demand really is. And there again, digital helps us integrate some of this flexibility, and it allows for things that in a standard routine care visit are not possible. So I think routine visits will change, but they're not going to go away. On the contrary, if you ask people with diabetes what they really want, they want more flexibility. They want to be able to talk to the doctor on demand, meaning tomorrow if necessary, but maybe not for half a year if there's no need. But they still do want to see their doctors and their nurses. What they don't want to do is they don't want to spend these very few precious minutes they have every couple of months talking about their next prescription and the standard things and looking at data that you could as well do by, as I said, by email or by a video consultation. What they would really care about is have meaningful conversations with the doctors that start with a very basic question, and that is, how are you? And in today's world, we very rarely have the time for that because we need to get through all these routine things that could be done digitally, and they have been done digitally, especially over the last months. So if the changes in routine care lead to that we can actually come to our doctor, sit down, and have, even if it's just 15 minutes of time to really talk about, from my case, how am I doing? What's on my mind? And it might be things that are not on first sight medical at all, but that are so important because everything is interwoven. The mental health side of things, the family side of things, the job, stress, etc. These are conversations that we have focused on way too little in the past. And it's not maybe something that works digitally so well, but because other things can be taken off the agenda and moved towards digital, we might have time for that, which would be great.
Yeah, that sounds great. I think we talked, you and I, when we talked that the relationship with healthcare professionals is going to change, and I think probably has been changing rapidly. Is there, are there people with diabetes from whom virtual care is not suitable?
I am very sure there are many, and we have to be very careful that we don't leave anyone behind. So there are people that are just not comfortable with anything digital, be it for privacy reasons and for concerns that some are more concerned about than others, be it for knowing how to use a computer or even having access to one. So that is something that I think we have to be very careful about, that there's great opportunities in digital for some, but there are others where this may not be wanted or may not be suitable or may not be accessible. And for those, we have to make very sure that we don't push people into the digital world if they don't want to, or can't access it. So it's something that also we at IDF Europe are very careful about, to mention that, hey, don't forget that there are people out there who might not want to do this.
So that's good, Bastian. And then I'm wondering, how we as clinicians who are working in diabetes clinics, isn't it going to be complicated for us to plan ahead? We somehow need to evolve our clinics in such a way that we have slots for people, for everybody, for in-person visits like you describe, and then maybe some space for people to continue attending because simply it won't work for them virtually.
Well, that's the great promise behind integrated care, where you have all these different routes and you're looking at everything. And actually, I think this is where the nurses and the doctors play the most important role. They know that. I mean, who better than the frontline workers, doctors, nurses, people working in the offices, in the clinics? They know their patients. They know people like me, and they will be the best ones to judge whether or not for this specific person a certain digital solution may work or not. We just have to make sure that there's not commercial pressure to move everything to digital, even those that don't want to. But I think as long as we keep that personal touch to everything, which is, again, what people with diabetes also want, and I think what nurses and doctors also want, we'll actually be doing fine. I see more opportunity in this than concerns, actually.
That's nice to hear, Bastian, because I think your perspective on this is probably the most important that we're going to hear to some extent, because you represent the customer. Can I ask you change tack a little bit?
Yeah.
One of the perceptions about medical technology and diabetes, that it's all about type 1 diabetes, and I think that's a misconception actually. But and I know you also agree. But let me then ask you, what's the vision for technology supporting the care of people with type 2 and maybe even preventing type 2 diabetes? Have you thoughts on that, Bastian?
I think there is indeed this preconception that all this tech is type 1 focused, and to some degree currently right now that may be true. For example, there's a lot of focus right now on CGM technology, on closed loop insulin pumps, etc. And this is, at the time being, primarily due to cost reasons, this is type 1 technology. On the other hand, I would advocate for CGM for everyone with type 2 who's on insulin, by the way. But for the time being, with the costs we're looking at right now, that at the moment might be difficult. But then, digital also has a lot to do with raising awareness, with reaching out to people, with we did a great campaign in Germany 2-3 years back on reaching out to those that may be at risk of developing diabetes. We know there's these risk assessment tools that are actually quite easy. It's a couple of multiple choice questions. And we did a campaign where we screened more than 50,000 people around World Diabetes Day 3 years ago digitally. Now, this is something that is great. We can implement these kind of solutions in public spaces, in campaigns like that. And these are very much on the type 2 community. And then also, going back to apps, although, as I said, I'm not the best friend of those personally, but that's just my personal opinion. There are great apps out there that are of great support for people with type 2, even if they're not on insulin. It starts with very basic things about reminders and staying in touch virtually, and as well as through, just making sure everything is running well. But so although there is this preconception about diabetes tech being focused on type 1, I don't think that is the case. I think it has a lot to do with activating the people with type 2, because here's the thing. The type 2 community is very much in a place which is ruled by stigma and by taboos. And digital also has a role to play here through smart campaigning, through advocacy, through awareness. And then we can really get to, this is not necessarily digital technology, it's more digital pathways. But then there's a lot of people out there we can reach and then also treat better and help them manage themselves better.
That's good. I think that's really positive. It's another really important message from this. Bastian, I have a last question for you. It's a little different as well. This is something that I've been hearing, and I think I've heard others discussing, that the COVID pandemic has had an effect also on the position of people with diabetes to some extent. And I'm trying to find the right words for this, that it's made them more sort of passive, more like the patient again. Do you know what I mean?
It's actually something I said in our very first call that
I was sure I heard it somewhere. Would you mind saying something about that?
I was actually saying this in relation to myself. I'm not someone who likes the word patient that much, because it still carries this. Also, you were talking about the relationship between doctors and people living with diabetes. It has this a bit of a top-down hierarchy notion to it, the patient who is being treated. But from my perspective, when COVID really hit, when these lockdowns came, when there was so much media noise also around high-risk groups, etc., it made me feel more vulnerable than I have in a very long time. I've been living with diabetes for more than 20 years, and I've never been very, very silent about this. But when this thing first hit, I felt vulnerable, and I suddenly saw myself as someone who might need a doctor to take care of me, versus usually I would always think that I am the one taking good care of myself. It's a self-management thing, diabetes, whether it's type 1 or type 2. It's mostly, diabetes type 1 and type 2 is with you 365 days a year, 24/7. It is you who is managing your disease, and every person living with diabetes knows a lot, some more, some less, but they are the ones who are dealing with that every day. And the doctors only come in every couple of months for a few minutes or for half an hour. But COVID did change that for many. They felt vulnerable, they felt as a patient. And I think that is something important to have in mind also when we move forward and try to find how we can alleviate that. And something that helped a lot is opening up pathways like, can you maybe just click on a WhatsApp or on a Facebook or on some other Zoom video call tool and just say hi to your doctor if you feel you're in a bad position and you need someone to talk to.
Okay, that's great, Bastian. We'll leave it there for now, and I'll come back to you in the questions. I think that's, for those of us who are working in clinics at the moment, there are a lot of messages there because COVID's not getting any better. It's a lot worse now than it was when we had our first webinar. Bastian, thank you very much. Great to talk to you and look forward to coming back to you in the questions. I'm going to move on now. Got to keep the time here. To Tadej Battelino, who on my screen is beside you, Bastian. Tadej, welcome. Thank you very much for joining us. You're also a very busy guy, I can see. Tadej, let me introduce you. Tadej is a famous diabetologist here. He is professor, head of pediatrics at the university in Ljubljana in Slovenia. But he's a big national leadership role, but he's also an expert at a European level on diabetes technology and co-organiser of the annual ATTD meeting, which is the premier event for diabetes technology. So Tadej, it's great to have you. You're a pediatrician, so you have many hats. Can I ask you straight away about this? How about all of this for children? Where is it going? Give us a little view on that.
It's interesting because first I would like to thank you for the excellent idea of having this paper out and of having this webinar, and for all your energy you're putting behind this, John. I really think it's extraordinary, and I thank you for this. People, whenever they discuss children, they tend to scotomize that every child had at least one parent with him who is always an adult by definition. Mostly two, sometimes there are grandparents with them. So pediatrics is more or less a family business, if you want. And obviously, if the children are small, we play with them, but we teach adults, parents, how to deal with it. And it's interesting because in this particular situation, the person we talk to does not have diabetes. It's actually the child that does. So it's a little bit, how to say, even more interesting and tricky. And trust me, no child wants diabetes, that's for sure. So it's a very different kind of interrelationship in this situation. And then all these people become young adults and they still don't like diabetes. But I think, what's important is that we don't mix roles. I mean, it's people with diabetes that manage their disease. And it's our role as diabetologists actually to support them in whichever particular area or field they feel they need this support. And I can only agree that it's mostly on the personal level rather than on the technical level. And here, I think it's the very big opportunity of the data from continuous glucose monitoring because it's intuitive. And when we switched from very, very difficult parameters on the advice from people with diabetes like Kelly Close and her team and several others from the United States, we now actually use terminology and data that is intuitive also for people with diabetes. So we basically use what they suggested is close to them. And the second change is that it's prospective. So we want to say, look, I mean, you look your time in range at noon and you still have 12 hours to improve it. So it's not that you come, you see your doc and you show your A1C and everybody's crying. That's over. That's more like a confession with a priest rather than a discussion with a physician. What I like is, I say, look, I mean, every day has a future, right? So let's look into the future. So if at the moment that your time is range is 40, that's fine. That was in the past. We cannot change this. Nobody can. However, we can change the next couple of hours or the next half a day. And this is the type of discussions that people with diabetes, at least in our environments that I work, actually prefer. And obviously, in this times where we are online with people like we are now today, actually, it works even better. It's lighter. So I personally believe that for families that have children with diabetes of different ages, our clinic is from 0 to 30 years. Actually, it's personal contact that matters. So I don't think that this virtual will completely replace what we are doing. But I think what we learned is it can beautifully supplement it, because sometimes they're fine. They don't need us. If they don't need us, they shouldn't see us. Right. So it's a beautiful additional option, actually, we all have now, and I think we can enjoy.
Yeah, you're agreeing. You're echoing what Bastian has just said, and it's nice to hear it. Tadej, can I ask you, because in your role running the ATTD meeting, you know a lot about what's going on around Europe in this field. Are there big differences in readiness around the European countries for this? Can you comment on that?
Here also, it's not nice to say, but the pandemic helped, actually. I think several countries push reimbursement through because of the data that appeared in the literature. So I don't believe that people are different. It is in my experience, seeing people from all over the world, people are basically the same. I very strongly believe in this. And people are obviously ready to use what's better. I mean, I understand in Germany, everybody likes Porsche. There's no somebody that says, Porsche is, not a good car, I don't want it. It's ridiculous. And good technology helping people with diabetes is good and everybody wants it. It is the question on how to provide this option to people. So we have to accumulate data to persuade public insurance systems when we discuss the European Union to reimburse. And this has happened. It has happened even in the United Kingdom, where there was, as you know, a very tough barrier. And now I just learned from Twitter, 80,000 people are reimbursed in the United Kingdom with CGM. 80,000 people. So that's really a big number. So I think diabetologists are the real problem. If you ask me, are diabetologists all over Europe ready? That's a more tricky question. And I am afraid there are still pockets, even in Europe, where people are diabetologists are less ready to adopt, or teams for diabetes. And this is sad. And here again, it's our role to actually change this.
How do we do that? How would you propose we do that then, Tadej? How do we get those stuck in the mud diabetologists moving?
It's funny. It's funny. What I think is we need to connect with people with diabetes. They do this best. So I have several experience in my local environment. So this organizations of individuals with diabetes contacted me, and we addressed this issue locally, and it worked. When people say, look, this is what we want, then physician is in a difficult position to say no. So, it used to be different, but now I usually use local associations of individuals with diabetes, and we do a program together, and we agree on how to educate local diabetologists and teams, and it usually works. And then, the tides turn, and it starts to flow, so then it's easier.
That's great. So that's a really important message. So the policy and guidelines can be driven by people with diabetes. Let me ask you one little quick last question. It's not a small one, but when you and I spoke, Tadej, some months ago, I remember you saying this, type 2 diabetes will change immensely. I don't know if you remember saying that. So type 2 will change immensely. I also asked Bastian this question, because you're a pediatrician dealing mostly with type 1. So how do you see what's going to happen with type 2?
Well, I actually, due to the role, see a lot of people that use insulin in type 2. So this is one group. And they will not be different from people with type 1. Those that are on multiple daily injections or an insulin pump and started as type 2, but then, of course, because of the failure of beta cells, ended up on full insulin replacement, are no different. So the first part is done. And then you have people on combination therapy. And there I believe that connected pens, not only for insulin, also for all injectable therapy in type 2, being, GLP-1 receptor agonists, will have a connected pen, will have a sensor, and will have an app to manage the two. And there is a beautiful study from Rich Bergenstahl just published on Onduo, and it works beautifully. And there are several others, as you know, the advisor now is for type 2. So I think it will be a connection in between a specific dose recommending app, and then that will include all the different therapy, injectable and oral, from an individual with type 2 diabetes. Obviously, initially, where the therapy is still small, it's a simple one. It will likely include some coaching on lifestyle. But then when type 2 diabetes gets more and more complicated, so will the app. And in the end, it will be undistinguishable in the end of this type 2 road, undistinguishable, I believe, from type 1, which it should be, because, the body doesn't know it's type 1 or type 2. The only thing the body knows is that glucose hurts.
Okay, great, Tadej. That's inspiring. Great. So I'm going to leave it there so they can continue. We'll come back to you, but they're great words from a pediatrician on the future of type 2. So that's great. Okay, thank you, Tadej. Next is Brian Kennon, Dr. Brian Kennon. Brian, thank you for your contribution to the paper, because you did help me giving me a briefing on what's happening in Scotland, which is one of the countries in Europe with really good diabetes data systems. Brian, just to those listening in today, Brian is a clinical diabetologist, a consultant in Glasgow, and he has a very important position because he's the national clinical lead for diabetes services in Scotland, and he advises the chief medical officer of that country. And he has a big interest in this field. Brian, thank you. So I can see by the look of you, you're working today, and thank you for making the time to talk to us. Can I ask you about a little bit about Scotland first? You're leading the clinical diabetology there, and you've been involved in a national diabetes improvement plan. Can you tell us a little bit about that? Because I know on previous occasions you've told me you've got great data, but it's very difficult to improve outcomes. So can you give us a little idea about what you do and where it's going?
Yeah, so good afternoon. And first of all, John, can I just echo everybody else's comments about your drive to move forward this agenda? Because actually it looks as if you're some sort of psychic, given the COVID pandemic and the need for digital solutions. So well done for being ahead of the curve. And thanks very much for the opportunity to comment on the paper and have this discussion this afternoon. So the Diabetes Improvement Plan, I think the first thing we learned was that wide stakeholder engagement is important, because this is effectively the Scottish Government's plan for how we look to improve diabetes care. Now, we're now 5 years into that plan and we're looking to refresh it. And we've identified 8 priority areas. But what's quite clear is that any of these policy plans need to be agile. And COVID has highlighted more than ever the requirement for agility. And I think as a diabetes community, we should make no apology for being opportunistic as well. And that comes across in your vision document. And whenever I speak to senior civil servants, politicians, they are well cited on the fact that diabetes and obesity contribute to adverse outcomes. And I think as a diabetes community, that offers excellent opportunities to think what we can do to try and improve outcomes. We have been fortunate in Scotland to benefit from over 20 years now from colleagues in Tayside's foresight of the importance in data. We have a national IT system, Sky Diabetes, that has over 99.9% of all people with diabetes in Scotland on it. And we're now looking to extend that into the pre-diabetes space as well. So that data is very, very powerful. It's integrated to primary care systems, prescribing systems, laboratory systems, and probably the unique element is My Diabetes My Way, which is a citizen portal. It brings back to the comments that Bastian said about how with COVID, it's back to, instead of being a person with diabetes who leads on their own care, it's how do you stop going back to being the patient who somehow is subjected to a hierarchy. So having a citizens portal where people can access their own information, further education, I think is really key to driving that. So we have to be agile and we have to be opportunistic. But I also think a key learning that we've had is the need to align to other people's priorities. I think we have been guilty in diabetes for a number of years of trying to solve our own problems, when quite often issues around data integration, data governance, e-health, IT solutions are out with our gift. We need to recruit other people to help us navigate that landscape. So trying to align policy with as many other policy areas where diabetes might benefit, I think has probably been a key learning as well. So agile, opportunistic, and data, I think would be the key things that I've learned.
Great, Brian, and you know, this is a kind of a simple question, but you know, you're in clinic today, I think, by the looks of you anyway. And, how are you adapting in your diabetes clinic to COVID? What have you been doing? Is it all virtual, or can you tell us a little bit about that?
Yeah, actually the pajamas or the scrubs are because I'm on call for acute medicine today, so I can vouch for the fact that COVID is indeed increasing across Europe, or at least certainly Scotland. So that was a key change. We suspended many of our diabetes services in adult care so we could concentrate on frontline services. Now, that very uniquely gave us an opportunity to reconsider how our diabetes service should look like. And we have pretty much revolutionized, or at least transformed, how we now deliver care. I notice in your vision paper, you highlight that 80% of consultations may be virtual. We're actually at 90% of our consultations are now virtual. Wow. We have, and it's back to Bastian's point as well about not one size fits all. So we now have clinic templates whereby 2/3 of appointments might be virtual, 1/3 may be face-to-face, but also some space for MDT discussions, because we all recognize this is a team sport and we all need to have that integrated team approach to make it work. So that has changed significantly how we offer care. I do think we need to be mindful about people getting the appropriate screening and appropriate investigation. So we've set up a 2-step model to try and address that, where people 2 weeks prior to their virtual consultation have their screening done. They can, in theory, access all of the results via the Citizens Portal, My Diabetes My Way. And then your hope is you then have a consultation that is a meeting of minds, whereby you're helping to support care rather than the historical diabetes clinic appointments that we've all been cited on previously.
So that's the third. I mean, Bastian talked about having time to say, how are you? And then Tadej was talking about tears and crying parents and crying child. That's a very important message there that you're saying as well. So by curating the visit with the data in advance, you have more freedom to discuss. Does that? Sorry, I'm talking now, but does that work for everybody? Brian, say, I'm just thinking, what about very elderly people with a lot of stuff going on? Does that work for them, or?
Yeah, I mean, I think we're all mindful that one size doesn't fit all. Personally, I worry about the digital divide and the potential to make inequalities worse. So I do think we need to have potential models of care that aren't necessarily dependent on a digital solution. outreach models to high-risk, vulnerable cohorts. But having said that, I think the digital. I've got an interest in young adults in transition. Our failure to attend rate is very high, much like many centres across Europe. With a digital solution, then actually most teenagers are happy to answer a call or speak to you on the phone. It's the coming up to hospital, sitting in the waiting area for an hour, to be condescended to as far as they're concerned and told the same thing again and again. They don't buy into that. Whereas if it's a phone call to say, how are you? How are you getting on? How can I help? Then we found that you get a better engagement and indeed a better conversation.
That sounds great. I think, Brian, to be quite frank, having done this vision paper and spoken to people all over Europe, we are a little jealous of Scotland. I certainly say in Ireland we're jealous of Scotland. You have a really well put together data system and great integration with general practice. So you have a lot to be proud of. But I can hear from you, and I know because you've said it before, it's not all rosy. Not everything has been solved, and there are policy struggles there. Okay.
Yeah.
Yeah. Go ahead.
Thank you.
No, go ahead.
No, I was just going to say that I think you're right. It's having data is one thing. It's how do you use that to drive improvement that's the big challenge. And actually, for me, it often isn't the policy holders that are the issue. It's actually the funders, and they are often different beasts entirely with different asks and different requirements.
Yeah. Okay, that's an enormously important point, and we'll come back to it. Make me come back to it if I don't, because that's a really important thing that's in the paper as well. Brian, thank you very much for that, and we'll come back to you in the Q&A. So last but not least, I'm going to move on to Ansgar Resch, who is here to fly the flag for MedTech Europe, who after all initiated this whole project. And MedTech Europe is a big organization in Brussels for all the MedTech companies, but there are 9 companies within that structure who have an interest in MedTech for diabetes. And there's also the diabetes sector group, and Ansgar is on that group and represents them today. In his day job, he is a divisional vice president for Abbott Diabetes Care in this region, Europe, Middle East and Africa, I think. So Ansgar, you're very welcome, and thank you very much. And on behalf of everybody, I want to also thank you and Tanya and the others in MedTech for kicking off this project in the first place. Can I ask you, would you mind if I asked you first, tell us a little bit about the Diabetes Sector Group and what it is and what you do?
Sure. Thank you, John. And first of all, thank you so much for leading this initiative. And I think we feel humbled as a group to have such amazing experts here on this panel supporting this work stream. In fact, I mean, the whole idea of the group is to make some enhancements in terms of prevention of diabetes, in terms of diagnosis and treatment of this pretty prevalent condition, diabetes. And this group has actually focused on two important work streams, which we believe are somehow interrelated. The first one, the one which actually brought us together here today, is digitalization and the opportunities we see with digitalization in advancing care for people with diabetes. And the other one is value-based healthcare, where it's about kind of rethinking how we basically design our healthcare system, how we incentivize healthcare systems, how we kind of eliminate the different silos we have and bring it together in a meaningful way for all stakeholders. So at the end, we have an outcome-based system, and a system which basically looks at total cost of care. That's kind of what we believe. And in all honesty, I also think there are some connections between these work streams, because I don't think you can do value-based healthcare, which I believe today is more than a buzzword, without digitalization. So it's a necessary ingredient to a larger kind of vision we have.
Okay, Ansgar, thank you, because actually it's a very nice follow-on from the last point that Brian Kennon just made. You know, he talked about funding and the discussions with funders. So I think everyone on this call and everyone who contributed the paper would agree that the value-based approach for diabetes care is excellent. But how can digital tools help us to deliver that?
Yeah. So first of all, what are digital tools? I think these days digital tools is almost everything we have. I mean, it's integrated systems of hardware and software, and not only software as such. I think it's the kind of orchestrated approach. It's the systems approach, and I think diabetes as a disease entity, as a discipline, is something which is especially amenable to digital technology. It is, if you want, a data-rich discipline of medicine. And as we have heard from the different panelists, I think the digital transformation in diabetes is already there. So it's a reality. We've heard in the market, in the different healthcare system. It's about how data is generated, how glucose is measured, how it is recorded, how it is transferred to different devices, to HCPs, to doctors, to electronic medical records, as we have heard in Scotland, to caregivers, right? And then basically how this data is analyzed, how this data is processed, and ultimately how it leads into decision making. And I think there are massive opportunities around that. I think digitalization is not kind of a technology which is just happening because of technical possibilities. I think it can drive a lot of effectiveness in care. It can drive better outcomes. It has massive opportunities around efficiency of care and kind of rationalization of utilization of services. It has some opportunities in terms of reaching patient population, for example, secondary care in rural areas. And if we project out how our kind of medical staff and our doctor landscape is evolving, I mean, we talk about shortness of specialists, right? And I think digitalization has a big opportunity here to kind of fill some gaps. But ultimately, I felt massively inspired by what Bastian said and Tadej said and Brian said. It's an opportunity also to bring a little bit more time for patients to care. And that's what's really important, because this is what ultimately makes a difference.
Okay, that sounds very positive. And Ansgar, can I ask you this question? I'm not sure if this is a strange one, but what are there digital tools out there that exist but we don't use? Are there, you're in the industry, are there things that we should be using or that are underused?
That's an interesting question. I think we as an industry, we need to provide opportunities, right? We give possibilities, and I personally believe that sensor technology is a massive enabler to better understand what's going on, and that does not only refer to the person with diabetes, to realize kind of how food intake, how medication, how exercise impact on glycemic control. It also obviously helps the physician to kind of work with the person with diabetes to come to better recommendations concerning care. So I think it's something which allows people to have an intuitive understanding of what's going on in their body. And as Bastian said, he would like to see this technology more broadly used also in the type 2 segment. So I think it's a massive opportunity here. And if we think about the costs, which was also implied and brought up by Bastian, it's a big topic, right? If we think about the numbers we have, with this condition, diabetes, 60 million. That's what we know from IDF estimations. It's a massive impact for healthcare systems, for budgets, but ultimately, I think we do not have an alternative to kind of tackling this at the root, because the costs of managing the complications and the consequences of diabetes, and we have several studies across different markets, are much, much higher than treating the underlying conditions. It's more or less in the order of magnitude of 4 to 6 times. So I think we have no alternative to tackling the condition as such, and doing our best to improve care.
Yeah, excellent point. And I think you're echoing, it has come out already, but I think us in the field, in the clinical field of diabetes, are frustrated, I would say, by our lack of ability to accurately track the costs of the complications, or to prove those costs, because many of our patients escape into other parts of medicine and those costs are not tracked. But yeah, it's a huge point, and nicely summarized there, Ansgar. Great. Okay, let's move on now, and so that we can have time to come back for Q&A. I want to make sure we do leave time for that. Before, I'm going to ask everybody who's participating today, you can send in your questions via the chat function, and we'll come to that in a second. Before we go to that, I'm just going to, I was going to do this at the end, but I think I'll do it now. So the following, I'm going to ask each of the panelists, I'll start with Bastian, go in the order we were, just for 1 minute. Here's the question. You know, we have here this vision of the future of diabetes care and the things we've discussed, and we have the pandemic that we're in right now. So my question is, if you could name one thing that you would do to make the vision actionable, what would it be? Bastian.
One thing that I would do right now relates to a question that was brought up by Tadej. He mentioned, how do we bring people to be more, accepting of this whole digital times that we are in. For me, digital is just a kind of step in between, right? We're now talking everything is digital health. I think a couple of years from now, we can just delete the word digital. Everything is digital right now. I think Ansgar just said it. We're already there. So digital health is just going to be standard healthcare. It's just that some people haven't understood that yet. What's the easiest way to get there? It's a bit of what we do in the DIY community in the We Are Not Waiting movement. Don't wait for maybe, and some of the industry people here might not want to hear it, but sometimes, and this is where COVID brings the opportunity, sometimes you don't have to wait for the big players to move because it takes forever. In Germany, we've been waiting for an e-prescription for over a decade now, and we still don't have it. Now, here's what happened over the last couple of months. We suddenly did have e-prescriptions. There is no tool for it, but you know what my doctor did? They did a prescription, they took a picture of it, they sent it to me by WhatsApp. I went to the pharmacy, and the pharmacy, they told me, ask the pharmacy to give us a call and we will confirm the prescription number. That's an e-prescription for you.
Yeah.
Sometimes it's that simple.
Yeah.
So one thing I would do right now is I would encourage anyone who's been waiting for the grand system and the grand software solutions to arrive, be a bit more like a hacking health DIY person, improvise, hack the system, and just move forward, and then the system will follow much quicker. Okay,
that's good, Bastian. I think that was the spirit of what we heard from several of the people who contributed to the vision paper. I think so. Yeah, nicely put. Tadej, in 1 minute, I think you're muted right there.
Right. Thank you.
One thing you would do.
Right. So I actually, if Bastian can do it with people with diabetes, I'll try to do it with my colleagues. There is still some reluctance on understanding that 30 years of legacy of A1C is of course lovely, and it's nice to be attached to something we trusted, and but it's time to move on, and this time to move on has started already. So I would just like to take as many of us on this beautiful boat, if you want, and travel together, because it brings benefit finally also to diabetologists. I mean, look, if I have means to do a better job, I should be extremely enthusiastic about it. And I very much agree what you said about Scotland. I can only add my kudos, actually. From our side, you need a system, you need a database, and you need ways to manage all the input you get from your devices efficiently, to be able to support people with diabetes. So we have work to do. And I would like to, onboard as many of diabetologists and their teams as possible to do this quickly and, in a way, let's say, that our Scottish colleague did.
Good. Okay, that's good, Tadej. Because coming from you, you organize a big meeting every year, so maybe there'll be a special type of session there like that. Great. Okay, Brian, have you got a 1-minute solution?
Yeah, it's funny because ordinarily I would have said infrastructure, 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 but I think in Scotland we've highlighted that we actually have got quite a robust infrastructure to make this happen. And for me, it's how do you actually get funders to pay for a lot of these developments? So to my mind, it's about building a health economic case. And I don't just mean financial. I think this is where Bastian and colleagues play such a vital role, because the person with diabetes voice is so strong in the ear, particularly of our politician colleagues. And how do we translate that into the funders for us in the NHS to health boards? But I accept that in other economies, it's going to be insurance companies. But how do we learn from each other and build that? And for any of you guys with insurance models, send me the information that makes an insurance company pay for this, because as far as I'm aware, they're not charities. So that would help our cases enormously. Learn from each other.
Okay, great, Brian. And Ansgar, you've had a couple of minutes to rest there. Have you got a quick, if there was one thing you would do?
Well, first of all, I love your proposals. I think all of them are really great. And, we at industry, sometimes we're really, really good in always pointing at somebody else. But, in all honesty, I think start with ourselves, start with yourselves and drive meaningful change. I think the condition diabetes is a tough one to manage. And I think we all need to be invested in this idea of making diabetes management easier for everybody. And that's something I think if everybody can sign on this one, I think we can make a lot of progress.
Okay, good. So you're talking about, quality of life, quality of care, and lessening the load. Great. Okay, let's move on to the questions, because I'm now beginning to get some very interesting questions on my chat feed here. So let me start here. And please, those of you who are participating, send in your questions and we'll do our best to put them to the panel. Here's one for Tadej, actually. Tadej, the question is, you work with colleagues on the digital clinic. What's that look like, and how can you make that happen?
Yeah, thank you very much. So it's easier than most of people imagine. So we use Zoom as we use currently, and we simply agree over the mail with a date. This is done by our nurses, and then we send an invitation for the Zoom meeting. It's 30 minutes. And prior to this, actually, we see, either from LibreView or from Clarity or from the CareLink, all the downloads. So they're already part of our electronic medical system. So when the Zoom interaction starts, on one screen is our person with diabetes together usually with the family member. And on the other screen, actually, is the download, from devices that this particular individual uses that we need for our discussion. And interestingly, those that were trained in the United States, like myself, you can even do a remote clinical exam virtually. There are certain rules that you need to follow. And, it's not the real clinical, but it's close to it in many ways, like inspection, injection sites, or troubles with the skin. All this basically can be assessed on the video session. So it's much simpler. And in the end, we dictate into our electronic medical system a record, a report that is sent electronically to the primary care physician and to the family that has this individual with diabetes. So this is all. It's very simple. Doesn't go beyond our Zoom meeting that we have today.
So we could probably even learn it if we had a chance.
Right.
I think that nicely echoes what Brian said about having the data ready so that you can have a better consultation. Now there are all sorts of questions coming in here. Here's one. This is for everybody in the panel, so I'll just put it out generally. This is from Donald O'Gorman as an exercise physiologist. How do you think digital health can deal with the integrated approach to care, particularly when other specialties are managing the person with diabetes? I guess I see Brian nodding. Very often we have cardiology, renal, respiratory. Brian, do you want to take that one?
Yeah, so it's funny because during COVID, because a lot of our services were suspended, then we were mindful that two specific cohorts still required input, and that was people with active foot disease and pregnancy. And we established very quickly a virtual diabetes foot clinic, and we were able to get buy-in from vascular, orthopedics, infectious diseases, as well as the other MDT members involved in foot care. But that allowed community podiatrists to review patients, to send in images, and we could view them all via our electronic portal and come up with an MDT discussion without face-to-face appointments, which had been suspended, and still hopefully put in management plans that allowed us to progress their patients' care. So that was probably a very good example of how digital solutions could be really useful, particularly for specialties that work in different sites where co-location is nigh on impossible. You can tune into a Zoom meeting or it's Teams. We use Microsoft Teams, and that works very well.
Okay, that sounds good. And I have just one question about that, Brian. For foot care, do you need really fancy photography to get good images for that?
No, so we're piloting a project just now where the podiatrists with the relevant, as Tadej said, about having the relevant governance processes in place, but they have got secure, basically their iPhones, they take secure images and they can put them onto our clinical system. So no, not at all. As soon as you start needing specialist equipment, your service has set itself up to fail. Yeah,
that's a good answer. I have one that's come in as well. This is for anybody who wants to take it. I'm not going to give it to anybody in particular. It's this one. Will hemoglobin A1C still be used, or is there a better way to represent and communicate glycemic control and variability when you're seeing the person with diabetes? Anybody want to take that? Bastian?
Well, I mean, we've been discussing this for quite a while, but I think we've already established that
do you want
to move beyond. So I think there's a lot of talk about, especially in the type 1 space, about time and range instead of HbA1c. On the other hand, people using CGM technology do have their HbA1cs at hand at any time, because you can calculate them instead of having to do a blood glucose measurement and then wait for a proper machine in the laboratory to do that. So I think HbA1c, especially if we look, to countries outside of Europe and where CGM will not be available for a long while, still will be staying important, but also where combined with a bit more sensitivity towards knowing that one single HbA1c can mean many different things. Maybe for some areas it doesn't necessarily require CGM for all. It just requires, I think that the thinking around HbA1c has evolved through CGM use, and time and range is definitely a better use, and variability and all of that goes along. But HbA1c will stay around. It is still the gold standard, and it will probably stay for quite a while, especially for all those on not on CGM and in type 2. Okay. And that's okay. That's okay, as long as we are being better educated amongst the patient community and, of course, amongst HCPs, that it's just a number, really.
Okay, good answer. I have one here now, totally different question from Mairead Fenlon. It's, do you think digital health has a place in the management of our frail population? I think I may have touched that earlier, but, say, for example, elderly insulin requiring patients with type 2 or elderly patients with type 1 who are frail. Any thoughts on that? Brian?
Yeah, I mean, I think as Bastian has highlighted, digital means different things to different people. The harsh reality is that this is actually now what we use to offer standard care, and you can see very quickly with devices like flash glucose monitoring, access to data, how actually digital health is very well placed to address this cohort. It's back to the point we made earlier about digital exclusion or the digital divide. So I do a remote and rural clinic in one of the far reaches of Scotland. And actually, because elderly patients often don't have the confidence to use online technologies, the health centre, which in their locality has set up a video conferencing room. So for the individual, they're coming to their clinic appointment in the community as normal, but they get to speak to a specialist service 3 hours away geographically or via travel. So I think it actually can support each other very well indeed.
Okay,
Brian,
Brian,
I can jump into that, John. Just
sure,
one.
go. Yeah.
You said, as I said before, you know, digital health is soon just going to be equivalent with healthcare in general. Digital is everywhere. However, there's good digital tools and there's not so good digital tools. And there are digital tools that are very suitable for people with other kind of complications, blind people, elderly people who are not so confident, etc. And there's solutions that are not so suitable. So there's one very important thing to keep in mind, especially for the people in the industry here. When designing these kind of solutions, design them with people like us, not for people like us, because that will dramatically improve the outcome. So when you do design a certain solution, no matter what it is, bring in people with diabetes, bring in somebody who is blind, bring in somebody with complications, bring in somebody with whatever it is, because they will open your eyes to what you need to do to make the exact same tool just better for exactly this population that you maybe want to not leave behind. That's all.
Great point, and that echoes that's come through today. Excellent, Bastian. I have another great question here. It's from Hood Tabit in Manchester. Let me read this out carefully. What can we do to make the case to healthcare payers to provide for better access to diabetes technology? He specifies CGM and Libra, for example, especially as we know these devices are invaluable in helping with the virtual clinic. What can we do? This is about how can we convince payers to make access to that. Anybody like to take that question?
Well, I maybe go first because we are confronted quite a bit with this question, and actually having your voice, having the voice of the experts here at the table, I think is probably one important factor here, because it's not only about the interests of the industry, of the economic interests, it is also about something bigger, something more meaningful, and that's about improving care. So having said that, maybe just in light of the situation we are in right now, right, in light of COVID, and Bastian talked about the fact how he felt vulnerable during this epidemic. I believe that specifically today, we almost have a kind of a moral obligation of making diabetes a topic in times of COVID, because we know that people with diabetes are vulnerable, and we know the opportunities we have, for example, with remote monitoring in kind of delivering care without exposing people to a potentially risky health community setting. We know that people with diabetes who are well controlled have a better outcome when infected with COVID-19 compared to those people who are not well controlled. So I think there's a big case to be made, and the data around this topic is coming in. And I think this is even escalating kind of the importance of making progress in this area, because the challenge is massive, right? And not only massive in terms of numbers, it's massive because each and every person with diabetes counts.
Okay, great, Ansgar, nicely dealt with. I have one for Brian. It's a follow-up question. It's a good one. What was the most helpful support you got from the Scottish Government to get to where you are today?
Yeah, so I mean, I work very closely with Scottish Government colleagues, and I've always found that they very much take their lead from the clinical community and the persons with diabetes, including third sector. So I've not actually found a barrier being at Scottish Government and policy level. It's been around implementation and adoption, and that's often a funding issue. And I suppose to touch on the last point, the last question as well, I think probably my dawn of realization of late is we need to work out what the health payers' priorities are and how diabetes technologies might help them achieve that. Otherwise, we're a disease-specific voice among many, and our voice often gets lost. So it's very much about aligning their priorities to our priorities, and that's easier said than done, but I think that's what we should work towards strategically.
Okay, well, it seems like you have made a lot of progress, and as I said, I think we can learn from each other as countries within Europe, because there is a lot of variability. I'm conscious now of time, panelists and audience out there. I think we've had a really great session today, and I think we'll wrap up now so that we're not right up against the gun. Let me just first of all thank MedTech Europe, Tanya Valentin in particular, who has been the person behind the scenes who has worked with me on putting the vision paper together, and Ansgar Resch for coming here today to represent the diabetes sector group. A big special thanks to our panelists for today, Bastian Hauck. Thank you so much for your input, Bastian, and for your support. Tadej, a man who's absolutely running from one thing to another, hugely busy at the moment with clinicians, and Brian Kennon on call today, taking a gap to do this. It's really, really appreciated. I think your contributions today have been so fresh and so open, and you can see there's a lot of harmony and a lot of lessons we can learn. I'm trying to think myself of my closing remarks, because this is what we aim to do, is to release the paper. And please out there, remember it's on the MedTech Europe website, and it's short and it's very readable. It's an unusual type of paper. It is a vision paper actually. So have a look at it, and the webinars will be on the site as well. Last one is there. This one is being recorded and will be there as well. I think there's a lot that we can take from this. In this worst year that we could possibly have ever imagined, actually what's happened is there's been a renaissance in thinking about diabetes care. And clinicians, people with diabetes, healthcare systems, payers have all been inspired by a must-do adaptation to virtual care. And it has actually been working pretty well so far. It's not perfect. We're still learning, just like we're learning how to use Zoom to run meetings, but we're making progress. And my impression is that it has greatly increased the focus on the needs and wishes and wants of people with diabetes. And that's really good. You can hear that coming through clearly today. Bastian's representing it very well, but my clinical colleagues are saying, yeah, this is how we make progress. Tadej put it very nicely. If we work with people with diabetes, we'll change the policies. I think Brian said it as well. And that's new for us. And I think that those of us who are involved in any part of diabetes care, it doesn't matter what it is, and the education of medical students, nurses, other therapists, young doctors, postgraduate training, it's going to change our lives. We're going to do things differently, because I think we're actually on the threshold of something very new. And despite everything, despite this very challenging year, my impression from the vision paper has been very positive, and even more so having participated in this webinar today. So thank you all very much for your time. Thank you everybody who logged on and for your great questions. Please stay engaged. This is a work in progress. We have to continue because there are many, many things to be achieved in the future. So thank you all, and goodbye for today.